Hi, everyone. Thank you so much for joining us today. My name is Lauren Wood, and I'm a healthcare practice lead at BCG Digital Ventures and a board member of the Tigerlily Foundation. And we greatly appreciate you making time to join us this afternoon. I am also joined by an amazing panel of individuals to talk about two very important topics: cancer and health disparities in the age of COVID. And before we get started, I wanted to quickly thank our sponsors for this event, Amgen and Immunomedics, and give a special shout out to Immunomedics and congratulate them on yesterday's approval of Trodelvy, which is the first ADC approved specifically for those living with a metastatic triple-negative breast cancer. So congratulations to the team, an incredible achievement for everybody.
So excited.
Congratulations. Congratulations.
So awesome. So excited about that.
Yeah, it's a wonderful achievement. Now, the goal of this discussion today is really, not only to shed light on the day-to-day experiences of those living with cancer during this time, during this global pandemic, but to also draw attention to the heightened disparity in health outcomes that is resulting from this global pandemic. And hopefully this conversation will inspire some much needed dialogue around how we can collectively address and improve these inequities to ultimately inform and improve health outcomes for all. So with that, I'd love to introduce the president of the Tigerlily Foundation, Maimah Karmo, and then proceed with the panel discussion.
All right. Hi, everyone. Thanks for joining. Lauren, thanks for opening this up, and thanks to our sponsors for their support, Immunomedics and Amgen. Tigerlily's mission is to support women under the age of 45 before, during, and after, and to work to end disparities of age, stage, and color. As a Black woman that has faced disparities before diagnosis, during, and after, it's so important to host this today, and so I'm happy to have you all on this chat with me. Ricki Fairley is my co-host, Ricki.
How is everyone today? And I'm so excited to be here and to have this discussion. As also a triple negative survivor and a Black woman, it's so important to understand the impact that this pandemic is having on our community. I always say, if someone had said to me, all you have to do is stay home and wash your hands and you won't get sick, it wouldn't be hard, but it's amazing that the world can't even respond to that. So thank you for this. Thank you to our sponsors. And I'm so happy to represent Sisters Network, Inc., which is a community of African-American women survivors. It's been around for 25 years. And we support a community that really has, our disease is different. And, mortality rates are higher, our recurrence rates are higher. And we have to fight like girls every day to make this disease go away from our community or be a part of our community. So thank you.
Thanks for all you do, Ricki. Really appreciate you. Our next panelist is, ask Nunny and Kayla Reece to talk about her background and who she is. Say a few words. Nunny?
Hello, everyone. I am Nunny Reece, and I was diagnosed in 2017 with metastatic breast cancer at the age of 39. I am a certified medical assistant. My background consists of pain management. And I started to advocate when I became diagnosed. I didn't see a lot of women that looked like me, and I was lost, felt alone. So I started to research, started to advocate, started to speak to others so that way I wouldn't be so alone. Come to find out, as I speak to other women, they felt the same. It became a big deal for me when I had people from my community to say they didn't think that Black women could get breast cancer. And when I asked why, they would say, well, we don't see them on TV, we don't see them in the magazine, we just don't see them out. And that bothered me. So I wanted to do more work and to advocate to let others know that, Black women can get breast cancer, and that wasn't the truth.
And Black women tend to have a 40% higher death rate, right, Nunny?
Correct,
so
correct.
The work we're doing today is really important, and all of you are doing. So thank you for sharing your story. I'm looking forward to hearing you share more over the next hour. Next, we're going to have Dr. Keith Crawford.
Well, good afternoon, everyone, and it's a pleasure having this opportunity to participate in this call, and it's very important. My background is I'm the clinical trials director and education at PHIN, Prostate Health Education Network. I do have I'm an MD PH.D. and I have a background in the clinical setting as well as in the sciences, and some of my background experiences with medical countermeasures and emerging infectious disease. Our objective was to make sure, PHIN's objective and our objective is to make sure that all cancer patients have a way to better understand how COVID-19 impacts their lives. And again, and that's why I'm pleased and honored to be a part of this call this afternoon.
We're very happy to have you. Thanks for all you do. I'm going to ask Craig to say a few words about his background and what he does in the community.
Hi, everyone. My name is Craig Lipset. It is such an honor to be here with this group, both the speakers in the audience and Tigerlily in general. My name is Craig, and as I mentioned, I lead clinical trials for a living. I ran innovation at Pfizer in medicine development, supporting clinical trials in oncology and other therapeutic areas where we were using different strategies to try to make trial participation more accessible for patients. I left Pfizer last summer. I'm an advisor in this field and work with a number of biotech and pharma companies and academic groups, primarily today around how to keep clinical trials running and participation accessible during this pandemic. Outside of the clinical trials work, I'm on the faculty at Rutgers in health informatics, and I'm also a patient and an advocate in pulmonary sarcoidosis. It's great to see you.
Thank you. Caroline.
Hi.
Hey, Caroline.
Yes. My name is Caroline Markopoulos. I've been living with metastatic breast cancer for a little over 5 years, and in December I was diagnosed also with AML leukemia. Like Nunny, I am going through this COVID pandemic while still in active treatment. My background is I'm a PhD computational neuroscientist, and I have a fair amount of background in sort of medical informatics and some other stuff. So I can see a little bit more into the healthcare system. And just since I've been diagnosed, just seeing sort of the disparities in care and what's available to me in different situations has been striking. And so I'm glad to be here to talk about sort of what things are like to be in care right now, and also to promote anything we can do to reduce the disparities, especially right now. Oh, and 3 of those years were on immunomedics drugs. I'm not triple negative, but I am a very fortunate for those 3 years. So I know it is Immu 132. I cannot, maybe Lauren can say the actual name of the drug.
Sacituzumab.
Yeah.
You can choose one of the 3.
Yeah, but yeah, so congratulations to Immunomedics, and really excited for the triple negative community, because I think it's been a fantastic drug for me, though my 3 years are a bit of I'm very grateful for those years. I'm a bit of an outlier there.
Thanks, Caroline.
Caroline, thank you. I'm very honored to host this chat. As a woman of color, an immigrant, first-generation immigrant, a TNBC patient who's, by God's grace, 14 years cancer-free. As a patient, we've really worked hard to establish respect with the industry, with scientists, and to be partners in the conversation around how to change healthcare policy, access, screenings, access to treatments. And in the age of COVID now, we're facing something even deeper and darker. People who are having a hard time getting access and facing disparities have more disparities now because of COVID. And so this conversation is really going to be casual. If you guys know who I am, I'm very, shoot from the hip. So just, be prepared for a very powerful, passionate, and thoughtful conversation. We want to get your input. And so if you have any questions, please feel free to put them in the chat box. We're all passionate. We may talk more than beyond the hour. If we don't get to your questions, we'll get back to you guys via email or some other conversational method post this conversation. So first, I want to start off with a question about the personal impacts of COVID on those living with cancer. And I want to talk to Nunny and Caroline. So can you share, you both are in treatment. I know Nunny very well. Caroline, you just met and you're so amazing. What is it like to be living with cancer in treatment during this age of COVID?
Okay, for me, it's difficult. Well, I can say really from the beginning, I was already pretty much like, washing my hands, being careful, being around people, watch my environment where I'm going. The fact I am in treatment, so I was already practicing those type things. But with this, with the virus now, I have to be even more careful about who I'm around, and I don't leave my home unless I'm having to go to an appointment, something of that nature. I can say emotionally it's very difficult because of the fact, I'm used to being around my sister, some of my friends, and just, being around family, and you can no longer do that anymore. And I really didn't have a lot of, and I'm sorry, y'all, I can be a big crybaby sometimes when I speak of this. But, my sister and I were really close, and, we lost our parents in 2016. So it's sister, my brother, and I'm used to seeing my sister like at least 4 days a week, not having to spend time with her or my best friend. That's really hard on me. And so what she started doing was she'll come to my house, she'll stand at my door, and we'll talk through the door, and I'm like, there goes my sister, you got my sister, and we just communicating that way. But it's just really sad because we can't hug each other. We really can't have that conversation. When I'm going through things, and it's really difficult face to face. We really can't do that anymore. So on the emotional side, for me, it's very difficult, and it drives you crazy. Is even going to my appointments now. My husband, every appointment, whether it's him or my sister or my best friend, they usually come with me. Well, recently, I had to go to the hospital, and I was devastated because my husband was not allowed to come in the hospital with me. And I was not expecting that. And I understand, what they're trying to do as far as making sure, it's not spreading. But for someone that time I was told I have progression. I have my brain mets. And not having my husband in there with me, that brought a lot of fear. Because you see the things on TV, you see the people that is that's dying alone. And you don't want to have to go through that, and that's the first thing that kind of comes to your mind. And to be in a hospital by yourself and going through this, it's just, I wouldn't even put that on my worst enemy. So it's very, very difficult, and people may not understand if they're not going through it, but I can assure you it's not an easy thing. It's really not.
Nunny, thank you for sharing, and I want to applaud you for sharing your journey through Facebook. It really is important that we share our truth. People see the numbers and they see the TV and metrics and all that the media shows, but you're so brave in sharing your truth because you are what's happening. You're representing a demographic that's severely impacted. You're facing a disease that could be deadly, it could be, and you're dealing with that fear and that anxiety, and now you're separated from those you love at this time and worrying about how COVID could impact your health, right? So thank you for sharing. We love you and appreciate you so much. And I'll come back to you in a second to have you share more. Caroline, can you share how this has impacted you?
Yeah, so I want to second what Nunny said about the fear of dying alone. So in December, when I was diagnosed with AML, and we got some sort of repeated bad news. The first treatment didn't work. They found some brain mets. And I was in the hospital 5 times between December and March. I got really sort of lucky timing wise in that the last day I was in the hospital was the last day they allowed 1 visitor. But I can only imagine receiving this bad news without my family. So my mom is here with us because I was really not doing very well. And just the thought of going back into the hospital is just very frightening to me, in terms of, you're going to have to pass through the ER, you're going to have to get tested, and then I'll be alone. And if I'm okay, then that's one thing. I'll have my computer and stuff. But if there's bad news, or if it's the end, I'll be alone. And I know they are allowing some people in at the end of life, but it's definitely one of the first things that came to mind. And I've just been really fortunate in terms of timing, in that the second treatment they put me on for AML seems to at least temporarily have put me kind of in a good place. So my day-to-day in terms of my treatment, they were able to only have me in once every other week at this point, which is really nice. And everyone at the hospital, I'm treated at MGH at this point, is just working so hard to make it the best they can for people. And MGH is kind of a machine that I just feel so fortunate to be treated at, because they have so many resources that so many other hospitals don't have. And so I think about that a lot. I think about how fortunate I am at this moment to receive the treatment that I have. Yeah.
But to your point, Caroline, there are hospitals where people are located that are not they don't have as much, as many resources and access. And Nunny's a case in point. And even beyond her, there are other people who have, further disparities. And so, food for thought for those who are watching, who are in any capacity could make a difference. Is, patients are in a place where they're facing potential, metastases, or there are metastatic patients, or are facing death maybe alone. So how do we impact this? Dr. Crawford, can you share a bit about what you're doing as a clinician and what you've seen in your position around patient treatments and treatment plans and access around the COVID disruption?
Well, what we wanted to do is, because of my background, I am the clinical director at FIN and responsible for education and educational outreach. What FIN did, and was extremely important, was to, one, draw a separation between what the public was recognizing as accompanying diseases, and really draw a line in the sand and say, cancer patients are unique. Cancer patients, if you compare the number of cancer patients in the United States with the number of people that are over 80, there's 3 million people above 80, but 18 million cancer patients. And to a certain extent, when this rush to make policy changes came into place, they left out the cancer patient. Say, for example, now you're starting to see recommendations to prioritize the treatment or triaging breast cancer patients. That was representing a group of hospitals that drafted a document. But information is being created, but not effectively translating it down. That's why we even took a second step, and we created a microsite that focuses directly on the case of the prostate cancer patient, but it provides educational information for all patients. And it clearly talks about the disease, and then questions, and tries to answer the questions that a cancer patient and a prostate cancer patient would have. Now, we started this back March 11th to push it forward, and we're happy that prostate, breast are now trying to serve as a mediator between the organizations that run it and really the cancer patient. So that's kind of what our objective is. And we still have a long way to go because there's policy changes. And say, for example, we have Caroline is in Boston at Mass General, and Nunny, I don't really know the organization to treat it, but there's a difference. And so between how we manage our cancer patients. And Nunny it was very important. There has to be another option than having a cancer patients, both Caroline and Nunny, sitting in a room by themselves. Either you need to test at least one member of the family who can participate, or really make arrangements to have a telemedicine program just for when you're receiving infusions. Those little subtleties, the humanity of care can't be left out as our rush to deal with the pandemic moves forward.
That gave me chills. We had a Twitter chat last night and talked about the same thing, that this is where humanity comes in, right? How do you balance keeping patients and caregivers who are in the line of fire, so to speak, with ensuring people have compassionate care during this time for all? So thank you for that. That's really powerful. Craig, what are your thoughts about, as a clinician and professional in this space, around COVID disruption for patient care, and what ideas do you have around that conversation?
Most of my work is around the conduct of clinical trials, and right now there is a huge impact on new medicines being developed because of the pandemic. New clinical trials for new medicines have been paused, so they're not starting as planned. Studies that were running have stopped enrollment at this time because of the pandemic, and all eyes are focused on the patients who are enrolled in active clinical trials, and how do we keep those patients enabled to have access to those investigational medicines, those medicines that are being tested. The implications of these delays will be rippled forward for years, right? If we have studies for a new medicine in cancer that are now being delayed 6 months because of the pandemic, in the next 2 years, we're going to still be feeling the impact of that. And so we have to find ways not only to take care of the patients who are in active studies and use the tools at our disposal to enable them to participate from home with greater access and convenience, leveraging telemedicine, leveraging home health. These approaches aren't new. I pioneered some of them at Pfizer 10 years ago. And so now we're seeing the research community needing to embrace these approaches, hospital at home, follow-up at home, so that patients can continue to access these new medicines and stay in these trials if they need that access. The consequences of this, though, I think will be that these approaches that were kind of brushed to the side because they were inconvenient for the doctors and inconvenient for the researchers will now need to become more mainstream. It's hard for patients to be able to access a clinical trial. They're not made for convenience. They're not made to be accessible. And they're certainly not made to be accessible to diverse and representative patient populations. But when we're now introducing these approaches that let more people participate outside of big hospitals, from home and in other ways, I think that's going to be one of the silver linings of this tragedy, that we will see change on the other side of this pandemic that continues to make it easier for patients to be able to participate.
I wanted to say one thing also, just to tag in on Craig. You said something that was very important. Like Pfizer has created technologies and studied technologies in telemedicine, It's very important to a point where Caroline is right, had to leave her home and go to Mass General. But there's a point where hopefully we can have more infusions at home. And even there are therapies that you don't have to come back and get an injection. I think there's like an on-body injector technology that's out there where a patient may have to have a follow-up injection. They don't, now those technologies should be really, we should really take advantage of those. And the government and the insurance companies are gonna have to come together and make it easier for the cancer patient to survive, especially during this period of time, because it's not gonna be, they wanna get us back going, and certain states are gonna open up. But it may be to 2020 before there's a clear opportunity, a window where we're not worried about this pandemic anymore. So where's the cancer patient in this whole process? And that's what we need to talk about. This is why this webcast was so important.
Keith, so many of the organizations I work with, I think at first were thinking this was going to be a 3-month crisis, that we had to manage making sure patients didn't miss doses, and that we need to figure out ways to manage and monitor patients for safety from the home during this time. I think eyes are now wide open that for patients living with chronic diseases, for patients who are concerned about going out in environments that threaten an already compromised immune system, this is not going to be going away until there's a vaccine. And there is not going to be a vaccine for at least another 18 months. And so for us to continue to make sure that patients are getting their care and that these new medicines can continue to get developed, because I mean, for us to wait 18 months and lose all that time for new medicines, again, will have a huge ripple effect for all of us. We need to start to deploy these approaches, which exist, and they've been here, and the ability to infuse in the home and monitor patients for safety in the home have been here. And to your point, now we're seeing them starting to get embraced. But I think that the upside will be how much of those now stick around and become part of the new normal, because none of us, patients or otherwise, are going to be willing to go backward.
And I think to that point, Craig, you know, even if they do become part of this new normal, they're only becoming part of a new normal for a segment of the population. You know, despite the fact that COVID has, you know, it's certainly increased pressure for health systems to advance development of digital or remote solutions. There's a large, you know, portion of the population that doesn't have consistent access to internet, certainly don't have, you know, access to smartphones or tablets, computers, and so forth. So they're not even in a position to consider those options to support their own care. But I also, you know, something that reminded me in what you were saying from a conversation I had with Caroline was just around her experiences, some of the remote care solutions that have been rolled out by MGH, by her entire care team. So Caroline, it'd be great just to hear your perspective on how that's been and what specifically, you know, your care team has employed to support the remote care.
Yeah, so there's about 3 different solutions going on at MGH. And I want to, again, make it clear that everyone is, you know, really doing their best. But sometimes for virtual visits, you get a phone call. Sometimes you do Zoom, and then there's a system that I think is through Epic that is on your laptop. And I have done all of these. The first 2 are easiest. The last one is a little more complicated because I don't think I've figured out how to do it on my phone. And then yesterday, my mom did a virtual visit. She's staying with us, and she did a visit with her primary care doctor. And I definitely had to debug it. It was not very straightforward. I am very sort of computer literate, but you know, I mean, it was incredibly not obvious how to do it. It required you to have Chrome on her anyway. So I think, you know, there's just a tech literacy requirement. Also, I feel, but on both sides, people are still figuring things out. And then to your point, I mean, there's a lot of conversation about, and we've talked about this, about, you know, like school access and access to digital school materials. And I worry that, you know, the conversation about, you know, if we're doing virtual visits, which could be very, very valuable, and especially the video ones, you know, if you're getting bad news and it's going to have to be virtual, I'd rather, you know, be able to see my oncologist's face. Or so I have leukemia and a breast oncologist, and my leukemia oncologist, I was actually in the hospital videoing with her on Zoom, and then my NP was in the room. So it can be kind of a complicated thing, but being able to see her face as she explained sort of some complicated things was just way easier and for me. But, you know, not everyone has smartphones. And so, you know, the same way that schools are looking to give out smartphones, and I haven't heard specifically, but hopefully, you know, help with internet access or give out tablets. I hope that the medical system also works to, you know, with the money they don't have, but, you know, provide that access for the patients who need it.
And Nunny,
Yeah, I mean,
want to build on that a little bit?
Go ahead. Yeah.
One experience around a call you had with someone from your care team that was a little concerning to you, but it would be great for you to share that with the group.
Well, as for me, I really haven't had, the experience haven't really been that great. As for me, you know, just a phone call and not about like Caroline, you know, being able to see my provider face to face will probably be something that I think I would like. But on my end, the experience like I said, hasn't really been that great, because it's like, you know, I'm trying to get through, when you're trying to talk to someone in your care team and you're having issues getting through the phone line, it can become frustrated. And you shouldn't have to be the one to really having to go through that. My providers or my nurse navigator or whoever my care team is, they should be contacting me as well to make sure that I'm getting the care that I'm supposed to be getting. I make sure I'm understanding everything. And I haven't experienced anything great with that right now. So I'm not happy on that end right now. And I'm just kind of looking at it as if, you know, I understand there's just so much going on both ends. There's tons of people that's trying to get through the line. So I'm trying to look at it you know, in that way, instead of trying to just, you know, being mad and angry off top. And that's something that I will talk with my provider and my care team this week. But so yeah, I haven't really been that happy as that aspect. It haven't been good for me.
I think that this was a perfect example of disparity. And we just want to talk about, we're not talking about ethnic disparity, we're just talking about regional disparity. And this is why this call was so important. Because maybe policymakers are on the line now listening and visually seeing the distinct difference between the two folks. And thank you for sharing.
Yeah, I mean, to your point, Dr. Crawford and Nunny and Caroline, some patients have a lot of access and support in video calls and the smartphones and the bandwidth on their phones to even view the doctor. And some patients have no Wi-Fi access, no smartphones, no video capacity to see, and less touch points. And so one thing for me, I'm going to speak my mind here. People have the collective power, whether it's policymakers, industry partners, there's money out there to ensure that people of color who are facing disparities have tools, have smartphones if they need them, have hotspots placed on buses or in churches where they could just come around and sit there and get on the Wi-Fi, and more touch points. So I feel like my thing is I want to drive the powers that be, we're the powers that be, but the other powers that be that have these systemic things they can change to make the difference, because there's no reason why we should have someone like Nunny or like Stephanie just sent a message on our chat box who may not talk to her doctor maybe once a week now, maybe versus twice, because she can't talk to him as much. He's not calling as much. He's only calling her once a week, and it's a phone call versus a visual to your chat about humanity, a visual conversation to say, I feel you, I see you, I'm with you, You're not alone, and we'll get through this. So I'm making a call to action to people who are watching. How do we figure solutions? We know the problems. We're going to discuss more of them. But this call is really about not just talking about our problems, but how can you all commit to making a change to ensuring that people who are dying at a 40% higher death rate don't go to 60% next year or 80%. So just food for thought. We're at the half an hour mark. This should have been a 2-hour call. Maybe we'll do a part 2. But I want to know, we talked about remote solutions that Caroline's been using, remote solutions that Nunny needs access to. But to Craig and Dr. Crawford, what are things that you can see that, so if you were to close your eyes and dream big and epic, not as what's happening now, but what is possible, what's possible in a year and a half that could be available now in the next 3 to 6 months? What can we ask people to help, or partners, industry, phone companies? What can we do about trials to get people access? We can't have people dying because a trial is put off for 6 months to a year.
Hey, Maimah,
so what are your bucket lists?
I'm sorry, can I build on your question? How can we,
yes, please.
How can we really build and replicate the care that people get one-on-one with their doctor in the office in a different way in this situation? And I think if you think about, Nordstrom.com, they go out of their way to give you a better shopping experience online than you would have in the store, right?
Yes.
So we're almost in that, but how can you replicate care in a way that people still feel the hug, they still feel the care of their doctor, of their nurses? I had a great relationship with my chemo nurse. How do we do this now in this situation? And just think about that. Think about how it feels to be alone in the hospital, as Nunny described.
Thank you, Ricki. Presti.
So most of the lens
yeah.
that I put on this is around the patient who's participating in research. And to me, I think the opportunity is, you think about that Nordstrom's example. You think about a first-class passenger on an airplane. A Nordstrom shopper is shopping for clothes just like somebody who's walking into any other store. A first-class passenger is still getting on a big metal object and flying to some destination, but some people are being treated better. They're having a different type of experience than the other people that are doing the exact same thing. And to me, that's what I want research participation to become. How do those heroes who are supporting the creation of new medicines for other patients like them, how do we give them that red carpet experience, and how do we badge them in a way that they are recognized for the additional contribution that they're making for all of us? And I think there are some hospitals and health systems that are starting to think along the same lines of how do we create that special experience for people that are supporting research regardless of race, color. But I think, to your point, Ricki, how do we then pull that into these more location friendly ways, right? And whether it's, now, if you're in a research study, very often they'll make sure that you get the access. Most clinical trials for a new medicine won't exclude you if you don't have the right technology in your home. They'll get you the right technology in the home to make sure that you can participate. But I think that many of those studies just haven't been designed to be accommodating of patient needs like that. They haven't yet shifted their focus out of making people come in and out of clinics and giving them the capacity to participate more from home. And so I think that, to your question of, what's that thing that maybe could have happened in 18 months and now we need to make happen in the next 6 and then make it stick, is shifting this focus so that people can avoid having to go to the clinic in order to participate in a research study. And in doing that, we can open up the doors for many more patients to be able to participate, those that don't live within proximity to get to Mass General Hospital or don't, live in that part of the country or just don't have access to that. So that to me is what I'm hoping for. And Ricki, the important point you made we can't just assume that we can replace that experience with an app or a chatbot or a phone call. We have to keep looking at these ways that keep the technology accessible, but keep this experience. I think this whole format that we're talking through right now is a great example of ways that people can still engage and participate and feel connected to one another despite being miles apart.
And
Right.
that was, and I just wanted to add on, Ricki, right now, if everything was perfect, then there wouldn't be even a disparity in care for underrepresented groups. Not only being a disparity in care just access to care that's already approved. When we talk about clinical trials, there's still an underrepresented population of people when it comes to breast cancer. African Americans underrepresented. Prostate cancer, the same thing.
Under 5%.
Under 5%.
Yeah.
Multiple myeloma. Still, all of these were underrepresented. And my fear is going to get worse because now you've basically taken away the common touch, being able to sit in a room and look at how your clinician and your team communicates with you. And there was always a need for cross-cultural competency in healthcare. Now there's a greater need. The next point was the solution. Advocacy groups will have to step up even more because we maintain the common touch. We take technology or complicated information and effectively convey it to the population of people that we serve. So from the from the technological aspect of it, we're, like Craig had said before, the technology is out there, but there needed to be some event to take place to shift us into bringing the technology to the home. Whether it's home infusion, we've been doing home infusion. Now, whether or not can we do home infusion from just a standard clinical practice to now moving that into home infusion in a clinical trial. We can remote monitor everything not everything in Caroline's location right now, but that they can be miniaturized and taken home if we want to do it. And the advocacy groups, Tigerlily has the responsibility, just like Finn has the responsibility to help move this forward, but maintain the common touch. We can't lose that.
Can I add something here? I think also at Sisters Network, we spend a lot of time just talking people off the ledge. And one of the fears is I'm in a trial, it's working for me. What if I get COVID? Am I going to get kicked out? And I think that's a factor. But also the benefit to technology is, we normally have an event that was supposed to be planned for this weekend, and we would have had about 8,000 people walk in and use it as an awareness opportunity. The benefit to Zoom, and I started making my own verb, zooming, we can actually reach more people as an advocate group, right? Because we can all be Zooming. And so looking at the 8,000 people that we would have touched at this walk, we can touch many more with technology if people have access to it. So we're trying to find ways to do that. And, we're doing a webinar on blackdoctor.org and, later today, actually, and we're trying to just reach more people and try to leverage the technology that we can to reach a bigger audience with education and information and that hug that we can try to give over Zoom. But
well, Ricki, you're awesome with that. You're really awesome with that. I think that it's really powerful that you do. You're so touchy with your team, people you're helping. You're always taking those calls and texts. And to Dr. Crawford's point, we're now responsible. And some patients, we have these conversations about why are we responsible? Because we're the patient having to advocate for ourselves. And now to push industry and corporations and the marketing companies, whoever it is, to change these systems. But it is our responsibility for our sisters to make these changes happen. One of our panelists, or one of our guests said, we talked about having a Nordstrom's more experience. The many people who are facing disparities of financial issues, of in the rural areas are nowhere near clinical trial sites. And many of those sites and or treatment centers don't have the right kind of technical resources or literacy. So even if they had these systems and tools to be able to use them. So I think there's so many layers to the issue. After the call, we're gonna have a separate conversation about drilling down about what we talked about and learned and then figuring out solutions, because there's so many layers around what we think is normal at certain places, like in Loudoun County, is not normal in some place that's more rural and more underserved. So I think those are worthy of discussion at some point. We have about 10 minutes
I
left.
see that Maimah in the chat, and I just wanted to add, when I share that about like a Nordstrom's or airport experience, it's more like to think about Nordstroms.com than Nordstrom's the mall. And if we can give people access to the right technology, can we democratize and enable people that don't live near a mall or near a Mass General or near an airport to be able to have that same type of experience? I think it's a hugely valid point that, you know, we have large swaths of patients that don't have access, whether physical or access economically or otherwise, to those centers. And so how can we use technology to open up that access? It's a great point.
Thank you for that.
I love the comment by Cindy in the comments, and it's what I say all the time. Treat people the way you want to be treated, the golden rule. So think about how you would want to be treated in that situation, and trying to get people who are in positions of power and control and you know, can do things around this to think about how they would want to be treated, how their mom would want to be treated, how their daughter would want to be treated. And if you sort of use that as a premise, it changes how you think about things.
And with you mentioned that, Ricki, I would like to say first I'd like to say, Dr. Crawford, I really appreciate your feedback, because it seems like you really get it. As a patient, you know, with the fear that I'm already facing with the cancer itself and having progression with the brain mets, I would like to say, like, even when I was in the hospital, you know, to me, I feel like it's unacceptable to not have that full-on connection with my provider. If I was in the hospital from the time, let's say March 30th, March 28th, I was discharged March the 30th, and I have not heard from my oncologist, and it's now April the 23rd. You know, that's a long time.
That's a long time.
Yeah, even though I was getting the whole brain radiation, and I was seeing my radiation oncologist, and I, you know, had a lot of feedback. But still, there was questions that I have. There was, you know, I needed feedback. There was stuff I was concerned about. And with me calling or reaching out, I should have received a phone call just to say, you know, hey, you have any concerns? I'm here. I haven't forgot about you. There's no way I should feel like, you know, they forgot about me, or my concern is not that important. To me, I just feel like that's just really unacceptable.
And you know what else is, before we take a split second and just think about this. Nunny's going through, Carolina's going through the same thing. We have policies that were put into place, self-quarantine, and nobody thinks about the cancer patient. I mean, Nunny, how did you feel when they're telling you self-quarantine? If somebody gets sick in your house, then you need to put them in another location. And you may have the luxury of having a place or the basement and place somebody. But there are people who have cancer who live in small quarters. How can they quarantine? Who understands how they feel, and who's answering the questions? And that's where I feel that some of the larger agencies, you know, the organizations have muscle, just like we have muscle. Sisters Network, Finn, Tigerlily, this is muscle. This is electronic muscle. But we're gonna have to be in a position to help change policy. It can't be, we can't do this stuff at the last minute. And you have people, I'm gonna give you instructions on wearing a mask from the CDC. Oh, a cloth. And they tell you, well, you don't want to wear an N95 mask. Well, that's not gonna, we need something to protect the cancer patient. So everybody's forgetting about the cancer patient. And this is very important for us to have this dialogue, continuing dialogue, because right now, there's a good example. If I say that an organization like the NCCN came out with a policy for breast cancer, and its recommendation for prioritizations of treatment and triage for the breast cancer patient. on that whole group of all those hospitals, I missed an advocacy group. At least one.
At the end of the day, everyone, I'm
Ricki,
sorry.
I want to talk to what you do. So Ricki, a lot of your work is reaching patients to help them to get access to screening, right? On the ground, you're doing that. You're doing these block walks, which I've been a part of in the past. And a lot of my work as well is getting on the ground in the grassroots communities to help them get access to screening. So a lot of our work, not just us, but many other groups that are doing screening outreach for women who are of color or any color, underserved or whatever, those are all on hold. So what keeps me up at night is thinking of women who may have been like me 14 years ago, who don't have access to screening, that will not have access to screening for a while, and how it impacts, their outcome, their health outcome, and their life long term. Just so many issues we have to think about.
I was going to ask you the same thing and say that I think that, Maimah, my bestie, you have done such a great job trying to keep peace. And, I had to learn in my breast cancer experience that my peace is non-negotiable. And we're all stressed right now. We're all, worried and fearful. And so everybody needs to find some peace every day. And I think that your daily outreach at Tigerlily has been such a good thing to bring peace to people. But with that, with those activities and engagement, and you should kind of speak to what you're doing, because it's awesome. Hopefully we'll be reaching people and taking advantage of this Zooming platform to reach people and talk about the importance of clinical trial participation, the importance of early detection and screening. Even though you can't get screening, you can still check your own breast and do your own self-care. And I think self-care is a place where you have really kind of taken a stand to help people find peace. And I think you can talk about that, Maimah.
Thank you, Ricki. I was focusing on you guys, not myself, but, one of the things I've learned early on, having been, gone through multiple wars and being a child of war, refugee, and cancer, single parenting, many challenges, is that how do you find peace in the midst of a storm? And how do you give people something to hold on to that reminds them of life and of hope and of faith? And so throughout this time, my dear and best friend, Catherine, passed away of breast cancer. I was with her until the end. At the end of her life, I couldn't be there because of COVID. So we had to say goodbye via phone, via FaceTime Live, which still is very difficult that she's not here, but that COVID didn't allow me to be with her. And so what we did in her honor is launch a program called the Pure Cat Initiative to reach patients and people and caregivers and physicians through which we offer 14 to 20 programs around life and around, being fit and meditation and breathing and talking about the collective global trauma we're in right now, right? How do we heal from that trauma and help others in the meantime? We offer Zumba dancing and Bollywood and pajama parties, all wrapped in living your life through COVID. Before COVID, we had cancer, and after COVID, we will still be struggling with women who are facing higher mortality rates and young women who aren't getting screened. So I think it's really important as we talk about these really, major topics, that we don't forget that people are still living their lives. And how do we love and serve and connect through these and finding joy even in this time of crisis? It can be a huge way for humanity to awaken to our collective power as well, So the emotional, mental, psychosocial support is really important, and is as important as the clinical and screening initiatives and all that. So just want to touch on that for a minute. Ricki, thank you for always supporting, and I support you, of course, wholeheartedly.
But it's having a community, the community of breasties, and we have an unconditional love for each other. It's not a club that you want to be in, but once you're in it, we have, the love is really important, and the community is really important. And everybody can help us, and we appreciate the love and support of our families. But when you talk to and connect with another breastie, it's just a different feeling, I think.
So what are you doing within Sisters Network, Ricki, because you're always, I think we're like twins, right? You're always like calling, texting, emailing, reaching out. What is Sisters doing, and what are you doing as, in your position to share what you're doing to impact patients through your videos, through the touch points, through the calls and texts.
Trying to use social media. You know, we have a really strong community as a way to reach out, but also we're doing a series, The Doctor Is In, on blackdoctor.org to try to give information. But I think also just answering the phone and being there for people is really, really important. So I talk to a lot of people every day, and I don't know how to stop doing that. I think that, you know, I'm getting text messages at 2 and 3 in the morning from breasties that are worried and can't sleep. So just calling them back and trying to respond and have, you know, I've gotten more Facebook messages than I've ever gotten in my life from people just reaching out. And I think that's really important, to call people back and have conversations and just touch people as much as you can in your isolation. So I think it's really important.
And that's the same. I just wanted to comment on that, and because from the standpoint of Finn, we're doing the same thing, and what we're finding is that we've had a survey, so we understand one of the more important things that people are looking for is staying alive, making sure their family is safe. Then they start thinking about treatment, and we'll find it very important to speak with people, because our lines are open at Finn for the prostate cancer patient. Call in and talk, because they're reading so much information outside, they don't have a clear understanding. That's why the Finn COVID-19 site was created, because we kind of organize it so we take away even the message that we're trying to provide is, don't get scared. Tigerlily, Sisters Network, Finn, we're here, and we understand it's not just the care, but what did you just say? That the having access by phone, the quality of life that's out there. You're basically telling people, this is how you proceed with your life. And it's just the care. The cancer doesn't control you. You have to maintain quality of life. You have to keep your mental health. I mean, even something as simple as bone health, keeping your bones nutritionally intact. All these things are important for excellent quality of life. And the fact that they can talk to you guys, because they're having a problem effectively getting into their clinicians. But the fact that you maintain that touch is so important. And just, I applaud you, because keep on going.
We're also
Thank
trying.
you. We love our work. And
Yeah, we do.
Ricki,
I was going to.
Ricki, go ahead.
Go ahead. I was going to say, we actually are also reaching out to some of our funders. We have a program we have an assistance program, and we normally raise the money at our walk that would have happened on Saturday. And so that didn't happen. So we're reaching out to our funders to try to help us build a fund where we can give some financial assistance. Obviously, it's not going to be as great as we have done in the past, but if we could just sort of take a little bit of pressure off of people financially, that could help with the stress and help them get some peace as well. I'm sorry, Maimah.
No, I was going to say the exact thing, because we talk every day. So we're in the same boat where the patients need support right now. We want them to stay in their homes, have their lights on, get their family's food, and have their water bill on. So we're working to get funding for people to get access to pay their bills. And so we're also working to get money for patients to be able to survive during this process. Somebody just put in the chat box too that before they were a patient, they were a person. And I think that if we, people are people before they're patients, and they're people during while they're patients and after. And so we can't forget that people need the emotional support, the touch points where he does. Caroline and Lauren talk quite a bit. Nunny and I engage quite often. Dr. Crawford, I've been stalking him lately because he's very, like us, very hands-on. So I think as we figure out these solutions long-term, the human capacity and touch points are critical. And I know we're past our 1 o'clock end of our call, but I want to thank you all for your time. Lauren, thanks for supporting this initiative. Thanks to Immunomedics and BCG TV, and to Amgen and Craig, Nunny, Ricki, Dr. Crawford. Caroline, where's Caroline? There she is. I just think it's been a powerful conversation, and we look forward to doing more of them. Lauren, do you want to wrap?
Yeah,
the call?
absolutely. I think, as you indicated earlier, we could continue talking for hours. So if you did enjoy this or you have any feedback or suggestions on topics for future discussions, please send them our way. Send them to info@tigerlilyfoundation.org. We'll put it in the chat as well, but we'd love to hear from you. I think we'll continue to find opportunities to hear from you on the panel today. And we look forward to reconnecting and hope everyone stays safe and healthy. And thank you again for tuning in, everybody.
Please stay home.
Thank you all.
Thank you.
Go ahead.
Thank you.
Thank you.